afternoon, everyone. You are very welcome to this webinar. My name is Adam Kalinowski, and I'm the president of Dystonia Europe. We launched the series of webinars in 2020 to give you the opportunity to learn more about dystonia and the latest news, and ask questions to specialists. And this is the 8th webinar in this series from Dystonia Europe. We are a pan-European umbrella organization for the national dystonia associations in Europe. But we know we have followers from all over the world. And today we have another important topic to cover, so I'm not wasting your time anymore. And I'm going to hand over now for a few opening remarks to Monica Benson, Dystonia Europe Executive Director. And Monica also introduce you to the topic and our great panelists. So enjoy our meeting. Monica?
Thank you, Adam, and hello, everybody. Very nice to be here with all of you. And I'm also delighted to introduce today's topic, which is DBS for dystonia, technical aspects, possibilities, and limitations. And this will be presented by neurosurgeon, Professor Veerle Visser-Vandewalle, and she is head of the Department of Stereotactic and Functional Neurosurgery at the University Hospital in Cologne in Germany. And today's moderator will be neurologist Professor Michael Barbe, who is the head of the research group, Movement Disorders and Deep Brain Stimulation. And you are working in the same team together with Professor Vandewalle. And Professor Barbe will keep track of all of the questions that you submit. I think that's all from me. Enjoy this session, and I will hand over to Professor Barbe.
Thank you very much, Monica, for the kind introduction. And also from my side, welcome to the webinar. We are very happy to be here from our center, Cologne. And I think I hope we can answer your question that are written down in the chat function. I will try to collect them during the meeting and then during the webinar, and then later I will discuss them together with the team and together with you. So I think I can move on and give the word to Professor Visser-Vandewalle to move on with her talk.
Thank you, Michael. So hello to everybody also from my side. It's a real honor for me to be invited here to be able to share with you my expertise and experience. I also find it very exciting to see all these messages coming by with greetings from all different countries from inside Europe, but also from outside Europe. I saw already messages from India, so that's very nice. I will share my screen now with you so that I can start with my presentation. Okay, so today's topic is about the surgical technique of deep brain stimulation. So if a patient comes for the first time to us, to me, for example, in the outpatient clinic, or to my colleague in the neurology department, he comes with a diagnosis of dystonia. And the first thing we do is look if the patient has been treated with different medications or Botox. So we first look if he's refractory to conservative treatment. And if that is the case, we propose an admission to the neurology department, so a hospital stay of about 1 week to perform pre-operative tests or tests for to see if the patient is a good candidate for surgery. So we perform a general checkup of the condition of the patient with a blood analysis, ECG, a clinical evaluation of the dystonia with the specific scales. The patient is also videotaped, so the specific scales, you know those, the Van Maarsen Dystonia Rating Scale or the Toronto Western Spasmodic Rating Scale, for example. We also perform neuropsychological tests. All the patients are interviewed by a psychiatrist, and we also perform an MRI scan of the head, a screening MRI to exclude structural anomalies. Again, so the patient comes first for the first time. We see if he's refractory to conservative treatment, and then we decide if we will admit the patient to the neurology department in order to do tests. And based on these tests, if we have all the results, then the patient is discussed in our weekly DBS conference. So every Monday in Cologne, we sit together. It's about a multidisciplinary DBS conference. So then the neurologist is there, the neurosurgeon, the neuropsychologist, and the psychiatrist. All the results of this week are discussed. And then we decide if the patient is a good candidate for deep brain stimulation. If that is the case, the patient gets an appointment in my outpatient clinic to explain him everything about the surgery, the risks, and the potential benefits. I also show the implants, and the patient signs the informed consent. Then the patient will get an appointment in the anesthesiology department before surgery. And then we also perform a second MRI that is called a Plannings MRI scan of the head. We use that one for the surgery. So during the initial phase in the neurology department, he gets a screenings MRI in order to exclude structural anomalies. And then when we decide that the patient is a good candidate for surgery, we perform another MRI, which is very thin sliced, and that shows the smallest blood vessels that is used for the surgery itself. Then what the surgical technique is performed, so we need this Plannings MRI that is performed 1 week or 1 day before surgery. This Plannings MRI is very important because it allows us to do the planning, to make a planning before surgery. So for example, 1 day before surgery, I take the time to look at the anatomy to decide where I'm going to put the target point and how I'm going to reach that target point. So where I'm going to make the burr hole in order to stay far enough away from the blood vessels. So here, for example, you see a blood vessel, and here we make a planning, and this is then the tip of the electrode. And we see that if we make a burr hole, in this case, we stay far enough away from the blood vessels. So then we start with the actual surgery. So now it is 8 o'clock in the morning, so to say, the day of surgery. We shave the patient's head. In case of men, we shave everything, but of course we have women with nice hair, female patients with nice hair, and then we only shave locally because it's very important that after the surgery, the patient can start right away with a normal life and that you do not see that he has been operated upon. So we shave the head and then we fix a frame. It's a metal ring at the patient's head under local anesthesia mostly. This is a so-called stereotactic ring. It's a reference frame. Then we go with the patient to the radiology department and a CT scan is taken. And then we fuse both the MRI scan and the CT scan. So here is a CT taken after the frame fixation. And this is the Plannings MRI that we have taken 1 week or 1 day before surgery. You see that the MRI is the nicest, gives the nicest images. So here we nicely see the anatomy, but the MRI scan has one disadvantage, and that is a distortion. So if you measure a distance here, it's not completely accurate because the MRI can move. We do not have this disadvantage with the CT scan. That's why we use a combination of both. we put the MRI scan on the fixed CT scan, and then we have the advantages of both. So then I take the time for the planning to calculate the 3D coordinates of the target point and also of the burr hole, again, in order to stay far enough away from the blood vessels. And what the target point is concerned, the pallidum, or the globus pallidus internus, abbreviated GPI, is the target of choice. So most frequently, we use the pallidum as a target point for stimulation. But also the thalamus is a potential target for dystonia. We use the thalamus specifically when there are structural abnormalities of the pallidum. For example, in the case of cerebral palsy in children who have had a birth trauma with multiple lesions in the brain, if the lesions are located in the pallidum, there where we want to implant the lead, then of course we cannot use the pallidum, then we take the thalamus as a target. Another example for thalamic stimulation is in the case of dystonic head tremor, where there's a high disability due to the tremor. So then we start with the actual surgery. So now it's already 11 o'clock. So we've used all this time for the calculations based on the CT scan and the MRI scan. So the computer has provided us the 3D coordinates of the target point and of the burr hole in relation to the stereotactic frame. So now we can start with the actual surgery. So the sterile frame is mounted on this frame. Everything is draped so that everything is sterile. And then we make a burr hole. The burr hole is small, has a diameter of 8 millimeters. And then we implant the test electrodes. So mostly we implant 2, sometimes 3, but mostly 2 test electrodes. You see them here. So you see that there's a macro tip and a very, very small micro tip. So with this micro tip, we can perform very accurate measurements of the electrical activity of the brain. And with this macro tip, we can perform a test stimulation. So in dystonic patients, there is an electrical disturbance deep within the brain at the level of the pallidum and at the level of the thalamus, and we are looking for this electrical disturbance. So what the test stimulation is concerned, in most cases, so in most DBS cases, this means for other indications like Parkinson's disease, we perform the test stimulation in local anesthesia. So the patient is awake, is not completely awake, he is sedated, but we can talk with him. But in the case of dystonia, that is not always possible because of the involuntary movements. And then we perform the surgery in general anesthesia. This general anesthesia allows us to perform a test stimulation because what we are looking for are muscle cramps or involuntary movements due to stimulation of a neighboring structure, which is the internal capsule. So we can test those with the patient being in general anesthesia. If the patient is fully awake, we also like to test the speech to look for speech disturbances. And what we can also test is if there are some visual symptoms like flickering. So I show you why this test stimulation is important. So here is the pallidum. So you can imagine that we cut the brain here, so to say, and that you look as such from the front in the brain. Then we have here the cerebral cortex, and then deep we have the white matter, and very deep here we have the gray nuclei, and this is the globus pallidus internus. So the target point, that is the structure where we like to implant the electrode in the case of dystonia. So here you see the structure again. Here's the globus pallidus internus, and then here you see the optic tract. So if we stimulate this, theoretically, we could induce some visual symptoms, but this is very rare, I have to say. But what is very important in the neighborhood, excuse me, here we have the internal capsule. And the optimal target point is close to the internal capsule, but of course, we should not implant the electrode too close to the internal capsule, because then we can evoke side effects due to capsular stimulation, which are these cramps or involuntary movements. So after we performed these measurements of the electrical activity and afterwards a test stimulation, we have found the optimal stimulation point of this patient so that we have no side effects or side effects only at high threshold. And that is the point where we implant the final lead. So this is the final lead with 4 electrodes or 4 contacts. Since 1987, DBS has been performed on a wide scale worldwide, and up until now, more than 200,000 patients have been treated with DBS worldwide. Since 1987 up until 2015, there was only one type of lead, namely a lead with circular contacts. So this meant if you switch one contact on, that you stimulate 360 degrees around this contact. Since 2015, different companies, namely Boston and Abbott, have the so-called directional leads. Macroscopically, they look similar, so they also have a diameter of 1.3 millimeter, but the middle contacts are subdivided into 3 segments. So you can imagine them here through this representation. So this means that we can switch, for example, this contact on and those off, so that you can stimulate in one direction away from, for example, the internal capsule that we do not want to stimulate. So here you see again this directional lead with the three segments here. So, oh, sorry. Here you have to imagine that you have opened the lead, then you see the different contacts here. So the contacts have a length of 1.5 millimeter, and in between there's a distance of 0.5 millimeter. But it's a very thin and flexible lead with a diameter of 1.3 millimeters. And then this final lead is fixed to the skull. So here the burr hole is fixed, is filled up with a specific substance that we call cement. That becomes very hard. And then we put the lead over the skull, and then with a very small microplate and screws, the lead is fixated so that it cannot move anymore. So we do this in the majority of cases on both sides, so at the right and at the left. And I have explained this very quickly now to you. You have seen that the surgery on itself is not really about a big surgery, so we only make 2 burr holes. But the preparation and the calculation and the measuring the electrical activity deep within the brain, millimeter by millimeter, takes a lot of time. So that's why this whole procedure takes almost 1 day, from 8 o'clock in the morning up until 2 to 3 o'clock in the afternoon. So now we have implanted the leads, one at the right side and one at the left side. And then of course we need a battery or a pulse generator, which is implanted under the skin here to the left side or to the right side, depending on the patient's preference. This is a small procedure. It takes about 45 minutes, and this is also performed with the patient being in general anesthesia. There are different types of pulse generators from different companies. For example, here you have the pulse generators from Abbott, formerly St. Jude's, and here those of Boston Scientific. So you see that each company has 2 types of pulse generators, bigger ones and smaller ones. So the bigger ones, for example, here Boston Scientific, are the non-rechargeable ones. and the smaller ones are the rechargeable ones. So the small ones look more elegant, they're smaller. Disadvantage is that they have to be recharged regularly. So we say that they should be recharged every week. Sometimes it's enough to recharge them every 2 to 3 weeks, but in order for the patient not to forget to do the recharging, we say that it's best to do this once a week. If the patient forgets about it, yeah, then he gets his symptoms back, but there's no problem for the generator on itself. So here is the non-rechargeable one. So a disadvantage is that it's bigger. So it has a length of 7 centimeters, and this one has a length of 5 centimeters. An advantage is that the patient can forget about it. He can forget that he has had this entire procedure, and he should not think about recharging. But the disadvantage is that a replacement is necessary about every 3 to 5 years, depending on how much current is necessary in order to have an effect on symptoms. A replacement of this generator, it's about a small procedure. It takes about 20 minutes and can be performed under local anesthesia. But of course, if we have a young patient, a patient of 30 years, and you have to think of the fact that he would need recharging every 5 years, then he would need a lot of operations in his life. Then of course it's better to take a rechargeable one, but which lasts about 25 years. So then the patient, after this second surgery, the patient stays in our department for a few days, and then he goes to the neurology department, and there the stimulation is switched on. So you know that there are different parameters what the stimulation is concerned. There's the pulse width, the frequency, and the amplitude. So the amplitude and the pulse width, they are important. They are the parameters what the strength or the stimulation current is concerned. What the frequency is concerned, we always stimulate with a frequency higher than 100 Hertz. Now, the difficulty, so to say, with dystonia compared with other movement disorders is that we do not see an immediate effect. When you have a Parkinson patient, for example, with tremor, and you switch the stimulation on and you start with 1 volt, for example, you can see an immediate effect of stimulation, and you know that 1 volt is enough. In the case of dystonia, it takes a while before there is an effect on symptoms. It can take about 3 months. So how do we know what current the patient needs? We do not know exactly, but what we do is we increase the amplitude and the pulse width up until the patient gets side effects. And then we stay just under this threshold so that we stimulate with a relatively high current without having side effects. What the contact is concerned, how do we decide which contacts we should switch on? Well, immediately post-operatively, we perform a CT scan with the electrodes. This is fused again with the pre-operative MRI, and then we look at the exact lead position and the orientation in relation to the anatomy of the patient, and so we can decide which contacts or contacts to switch on. For example, here in this case, we stimulate in a directional way with 2 levels. In this patient, we only switched 2 segments on. Now, another consequence of the fact that we do not see immediate effects could be that after a while, we decide to implant another lead. For example, this is from a publication of a center which has a lot of experience with DBS and dystonia, namely Montpellier. It's an old study, but it nicely shows that you can add leads after you have performed bilateral stimulation. So in these cases, those were all children with a general dystonia, and the initial leads were implanted here. This is the posterior part of the globus pallidus, and in all those cases, they saw that there was a good effect on symptoms in the arm, but not enough in the leg. And then they added another lead just in front of this initial lead, and then there was also a good effect on the symptoms in the leg. So here you see the postoperative CT scan with right and left 2 leads, one in front of the other. We have some patients who have 4 leads implanted. I present you here a case of a patient with a dystonic head tremor. It was a lady of 70 years old who had a dystonic head tremor and also a tremor in both hands. Of course, she was refractory to medication as well as Botox, and because the tremor was most important for her, we decided to perform a DBS of the thalamus. So VIM is a part of the thalamus in order to treat the tremor. This was done in April 2017. So here, this is the planning for thalamic stimulation for the tremor. And then immediately postoperatively, there was a very good effect on the head tremor as well as on the tremor in the hands. But after a while, the effect subsided. And then we discussed this case at our multidisciplinary conference, and then we decided to add leads in the GPI. So what we did, first we removed the thalamic leads, and then we performed a new Planung's MRI, and then we re-implanted the thalamic leads and also added 2 leads at the level of the pallidum. And then the patient received 2 batteries or 2 pulse generators, 2 times a Versailles Jevia, a rechargeable battery. We removed first the thalamic leads, because then we had the nicest MRI scan. So it is possible to perform an MRI scan after leads have been implanted, but then immediately in the immediate neighborhood of the leads, there are artifacts, and that might influence the calculations for the next surgery. So in case that we need to add more leads, we decide first to explant the initial leads and then re-implant those and add 2 leads in another region. So, and then the patient gets a patient programmer. For example, this is one from Boston. This is the one from Abbott. It's very easy. Then this allows him to adapt or to change the stimulation current within limits that are set by us. And this, for example, the iPad. This is the iPad with which the doctor changes the stimulation settings. And this is an iPod for the patient with which he can also change the stimulation current. And then what the charging is concerned, in case the patient has a rechargeable system, it's very easy. So there's a device that is charged with an electric current, and then without the cable, this is put in a kind of vest, and then the patient can move around. It takes about half an hour. So what the complications are concerned, every surgery, also stomach surgery or knee surgery or whatever, there's always a risk of a bleeding. But I have shown you that before surgery, the patient gets an MRI scan where we can see the smallest vessels. And before we start with the actual surgery, we can simulate the trajectory that the electrode or the lead will follow. And we can plan to make a burr hole as such so that we stay far enough away from the blood vessels. The result is that the risk of bleeding is really very low. It's actually lower than 1%. If there is a bleeding, in half of the cases, it's asymptomatic. So this means that the patient does not have any symptoms related to this bleeding. There's also always a risk of an infection. The risk of an infection is in our department 3.5%. When you look at the publications, there's a high variability. In some centers, there's a complication rate of an infection rate of 20%. Other centers say that there is no infection. I don't believe it, that there's never an infection. But of course, we do everything we can in order to avoid infections. The patient also gets antibiotic treatment, prophylactic, the day of surgery. This is what the surgery is concerned. Then what dystonia is concerned, there are also specific complications which are implant related. We see more lead migrations and lead fractures, so more hardware complications in the case of dystonia, and specifically in case of dystonic children. And the reason is that, like I told you, there's no immediate effect of stimulation. This means that immediately postoperatively or the first month, the symptoms might still be pronounced, and due to these movements, lead migration or lead fracture might occur. I have to say that lead migration is in our center very rare because of our fixation technique. We have seen lead fracture or fracture of the cable. And then, of course, there are the stimulation-induced side effects like speech disturbances due to stimulation of the internal capsule, and motor side effects, but this is specifically the reason why we perform a test stimulation intraoperatively. And even if it is not possible to test the speech, we can test the distance towards the internal capsule based on the motor side effects intraoperatively. But after surgery, it is possible, if we stimulate very high, to induce the side effects. And nowadays, there are different possibilities of avoiding these side effects in case the patient needs a high current to have an effect on symptoms, like, for example, stimulate with directional leads away from the internal capsule, or reduce the pulse width. This was it. I hope it was interesting for you, and I'm looking forward to hear your questions.
Thank you, Veerle, for your talk. That was very nice also for me, some new aspects here. I have followed the chat, and I saw some questions, and I will go through them now. The first question was on the risk rate for lead migrations and lead fracture, what you've shown in the last couple of slides. There was a question from Patrick, and he asks, what is the risk rate for that?
The risk rate, it's also, yeah. I have to say, I've never seen this in a Parkinson patient. So we're talking about relative risks. So we see it more often in dystonia, but even then it's rather rare. I've seen it in 2 children. 2 in 50 cases, something like that.
Okay. Yeah. Okay, thanks. Then there's another question just coming in. Can DBS be used for all types of dystonia? And this is similar to another question we had before, whether deep brain stimulation is effective for blepharospasm, dysphonia, Reiter cramp, and cervical dystonia.
Yeah, but you can answer this.
Yeah, sure. I mean, of course, I mean, when you look now, we have treated many patients with all these conditions. But when you look into the studies, there's a very important paper in Lancet Neurology 2014, where they had a sham-controlled study. So what they did in cervical dystonia, and this is the dystonic condition that is investigated very detailed. What they did is they had, I think, 60 patients, and they were randomized. They all received DBS implants, but only half of them were switched on. And the patients were blinded, which if they were switched on or not. And then in this sham-controlled study, they saw that there is an improvement of, I think, 5 points in the Twisters score, which is a dystonia severity score for these patients with cervical dystonia. So this was the first very important, or one of the very important studies on the effect. And we don't have these studies with 60 patients for blepharospasm and dysphonia. But we see in our patients that this can improve, but we only know this from single cases or little case series. So the answer is yes, all these types can improve, but we only have good data on the cervical dystonia patients. Or do you want to add something, Veerle, on that?
No, torticollis is a very nice, so to say, indication with nice results in general. Mm-hmm. And what general dystonia is concerned, it's depending on the underlying cause. For example, typically, the genetic DIT1 dystonias have spectacular results, but yeah, dystonia is a very heterogeneous disease, and
yeah, that's true. I mean, maybe that's also important for the audience. Veerle just pointed out that we have different genetic types of dystonia, which help us to maybe predict the effect of deep brain stimulation. But what is also important in contrast, for example, to Parkinson's disease, because here we have the L-DOPA test before the surgery, and that helps us to predict the effect. So if a patient does very well in the L-DOPA test, which we do pre-operatively, then we can tell that possibly or probably this is the effect that we can get with DBS post-operatively. So this we don't have for dystonia, so it's not so clear what we can tell the patients in advance.
Yeah. And if we doubt, for example, cerebral palsy is a good example. Cerebral palsy, so birth trauma, is a very complicated disorder, and we know that in general the results are not so good. But often the quality of life of the children and the family is so bad that we decide together, of course, with the family, that there's not much to lose with the brain stimulation because the risks of the implantation are so low.
Mm-hmm. Yeah, that's another very important point. There's another question just coming in, and then I have written up all the other questions, so we will talk about these as well. But there is one question: do you only do surgery for severe cases of cervical dystonia? So, or maybe there was another question in this direction. When do we perform surgery? I mean, how severe does the disease need to be that we start thinking of a DBS?
Yeah, I would say, but you can also add something to that later. I would say if there is a clear impact on the quality of life of the patient, then it's worth it.
Yeah, that would have been my answer as well on that. So it's not the severity. We have different patients with very different dystonic features, and the severity is also different. But if the quality of life is not good for these patients, then we can perform surgery on these patients if the expectations before surgery can be fulfilled. So that's also another important point, right? So we have to tell the patients what we think will happen after surgery based on our experience, based on the experience we made with the other dystonic patients over the years. So yeah, this is something. So everybody who has a reduction in quality of life and is not, for example, has tried Botox treatment or has tried medication treatment, but he's suffering from medication side effects or side effects of Botox, then he should think of going to a DBS center and simply ask whether this could be an option. Sorry, Barbe?
Like you said, Michael, unfortunately, we have no predictive tests. So this means that beforehand, we can never give a guarantee. And that might be, of course, very disappointing for the patient. That's why we find the input of the psychologist so important. So pre-operatively, every patient has a meeting with the psychologist in order to investigate, okay, if there's no effect or if we do not reach what the patient expects, how will he react? We find that also very important.
Mm-hmm. Yeah, that's true. Then there's another question on the different symptoms in dystonia. So, and if all can be targeted by DBS. So, for example, one question here asks cervical pulling to left, muscle spasm on the mandible, vocal tremor, right arm cramping, and so on, and pain. So, can we target all these symptoms with DBS or only a couple of these?
No. Yeah, we can target those. So we target the structure that is electrically disturbed, that is the pallidum. And then if different parts of the body are have symptoms, then we implant the lead as such that we can affect the different body parts. And what the symptoms is concerned, the dyskinesia, so the involuntary movements, mostly respond the best to DBS. But blepharospasm, also tremor, is a good symptom. If the tremor is the most pronounced symptom, then we might decide to do a thalamic stimulation. But the ones you just mentioned are all good symptoms to treat with DBS.
One important thing is maybe in spasmodic dysphonia is sometimes difficult. I mean, we see very good effects here, but as Veerle pointed out in her talk, we sometimes affect with the current the internal capsule. And then we sometimes see stimulation-induced dysarthria after DBS, but we can control this very well. First of all, by checking in the operation whether the electrode is too close to the capsule, and then it can be corrected, or even later with the directional stimulation that Veerle has shown. So this is, I mean, speech is very difficult to predict, but we have seen very good effects on spasmodic dysphonia as well in our patient. There's a very interesting question on one patient who says he had DBS surgery for blepharospasm, and his honeymoon phase was great. I hardly had any spasms for about a week. Can this be a prediction of a good outcome with stimulation? Veerle, I think that's a good question for you. And the next question is, and how is it possible that stimulation doesn't have an immediate effect, but the microlesion effect does have an immediate effect?
Yeah, that the stimulation does not have an immediate effect has to do with plasticity. So there's disturbance of the electrical circuits for years. And then, yeah, it takes some time for the brain to find a new balance. The fact that there might be a lesion effect without being an effect of stimulation, actually, I do not have an immediate answer to that. Do you have it, Michael?
I mean, the question was, is it a good sign for because this is a patient who was just operated, and I would say, yeah. I mean, this is well studied. It's a very good sign. Yeah. When you even when you have an effect post-operatively, then there's even a study in PD patients. When you have, without putting current to the brain tissue, you have a good effect already. Then this is a good predictor that DBS works later on with the current when the stun effect or the microlesion effect is over. Yeah.
This means that the hotspot, the optimal stimulation point has been reached by the surgeon. Yeah.
And then the question, why is the lesion effects immediate? My answer would be that this is a very strong effect. So you have to imagine that there is, of course, an electrode in the tissue, and there's a mild edema, and that leads to the microlesion effect. And nobody, I think, has studied this, but my guess would be that this is a very strong effect to brain tissue. And you have to imagine that the current we apply is a very small current ball that is applied to the tissue. So this is not really comparable, but I think nobody has really looked into that. It's a very interesting question. Yeah. So oromandibular dystonia can be treated with DBS. We said this before. And then there's a question, what happens when the battery stops working?
Yeah, the symptoms reappear. In case of dystonia, it's not always immediate. This means that there might be an after effect of stimulation, but nevertheless, the symptoms will come back.
Mm. And there was another comment, someone saying, how is the success rate of deep brain stimulation in cervical dystonia? We had said that already. What are the side effects? We talked about side effects as well. And then there was one patient who said, my doctor says, although he has migraine from the Botox treatment, my doctor says that I'm not there yet for DBS. So what can you recommend to this patient?
That's a question for me. But
Yeah,
I think it's difficult. So if there's no effect of medication and Botox has no effect or is not tolerated, I would say Michael, we would say, okay, let's test the patient. Let's do the test to see if he's good candidate for surgery. Why wait?
Yeah, exactly. I mean, what I saw through the questions is, how long should I wait before DBS can be performed? And that's very hard to answer. I mean, we would say that both treatments, Botox and medication, should be at least tried. And if there's insufficient effect or side effects, then we check in the hospital for a couple of days whether the patient is suitable for deep brain stimulation. That's how we do it. And but we also know that many patients many doctors treating with patients with Botox, they need some time to get a good idea and good understanding of the dystonia type the patient has. So it's very difficult to say after 3 times of Botox and it doesn't work, you should go for DBS. So that's that. I mean, the best thing is to talk with the doctor who's doing the Botox and to talk to the patient about the side effects, and then find a solution somehow. And there is a study going on at the moment that we also participate on, where exactly this question is tested. It's the StimTox trial, where you include patients who have a little bit of improvement with Botox, but not 100% improvement. And these patients are included into a trial and then randomized for DBS and Botox. And this study is going on at the moment, and this will answer the question whether early deep brain stimulation makes sense in these patients with cervical dystonia. Yeah. It's another study on cervical dystonia, unfortunately, but this is a very important question on when to offer this to the patients. So hopefully this will be solved. Yeah. So that's there were some questions on this issue. What must be done before DBS can be performed? Yeah. And then I have a question on sleep versus awake. There's a big debate going on. What is better for the patient? Maybe you can comment on this, Veerle, as well. There was one comment on this as well.
Yeah. So test stimulation with the patient being awake is the gold standard. So he's not completely awake. We do it what we call analog sedation. This means that the patient gets something so that he's quiet and he has no pain, but we can talk with the patient. So performing a test stimulation with the patient being awake is the gold standard, because then we can do the most optimal test stimulation. But of course, in dystonic patients, it's not always possible because of their movements. So then we do the surgery with the patient under general anesthesia. And it's not so what many people think, that we cannot do any kind of test stimulation. Then we can do it. We can test how far we are away from the internal capsule. So it's a kind of compromise in dystonic patients to look for motor side effects due to stimulation of the capsule. So that's also fine, because the alternative would be that we do not do surgery on the patient if he moves too much. So I think it's a good compromise, but of course, if we have the opportunity to do it awake, then we prefer to do it awake. That's the gold standard.
Mm-hmm. Yeah, correct. There's another comment it just came in. My rechargeable DBS was Medtronic in 2009, and it needs recharging every 2nd to 3rd day. And it takes 90 minutes. I have segmental generalized dystonia requirement and requiring 3.6 volts on both sides, probably. It was done in Oxford. How does it compare with your DBS patients?
I think it's a lot. If the patient needs to recharge every 2 to 3 days during 90 minutes, it's really a lot. Then I would think of a mechanical problem with the device.
Yeah, well, for me it also appears high, but of course we would need to have the other stimulation parameters. So volt is one parameter, but also how the pulse duration looks like, and how the impedance of the devices. But I would also suggest to check this, to check the electrode for any functional problem.
Or the loading of that, or the generator of, for example, if there's simply a good contact between the charging system and the generator, if there's a good contact, because it's a long time, 90 minutes, and 3.5 volt, it's not that high. Of course, the pulse width is also important, but I think it's rather high, every 2 to 3 days, 90 minutes. I would like to exclude a mechanical problem.
It's also sometimes the case, the generator is flipping. That's very rare, and it's only reported in some cases. But then, I mean, also the distance from the generator to the skin is also important. And if it flips by 180 degrees, it can sometimes cause these problems. But this, I've never seen it myself, but it was reported on conferences. But this should be also looked at. Yeah. Then there's a question on chronic migraine. Can DBS give negative effects on chronic migraine? I've not heard about that.
No.
I'm 23 years old and I have cerebral palsy. Is DBS an option? That's a good question for you, Veerle.
It depends on the symptoms. For example, if there's, so often in the case of cerebral palsy, there's a mixture of dystonia and spasticity. If spasticity is the main problem, then DBS is not the best option. If dystonia, and specifically if there are a lot of hyperkinesia, so involuntary movements, then DBS might be an option. But I have to say, in general, the effects of DBS for cerebral palsy are less pronounced than with other types of dystonia, like, for example, torticollis.
Yeah, correct. Are there any disease circumstances that makes a surgery impossible? That's an overall question for DBS, probably.
For example, if there are untreatable blood coagulation disorders, I've never experienced that. We have, of course, patients with that have anticoagulative treatment for like aspirin or anticoagulants. Then you have to stop those, of course, but it's not a contraindication for surgery. There should be no contraindication for general anesthesia. And of course, structural abnormalities in the brain might also be a contraindication.
There's another question which was asked very early in the chat on the side effects of medication. We know that, for example, trihexyphenidyl is causing a lot of anticholinergic side effects. This is a great burden to all the patients because these medications reduce dystonia if they work, but then you get dry mouth, obstipation, and different side effects, which are very hard for the patients. So the only thing, and then the question goes into the direction, what can I do? And the question is, of course, you can try another pill, like Nitomane, for example, but this makes other side effects like a mild Parkinsonian side effect. Unfortunately, we see this very often in the patients. So you have to talk with your neurologist if there are any other options, and maybe then another drug is with fewer side effects in your case. But there are not so many options in dystonia, unfortunately. And the more focal the dystonia is, the more often we suggest Botox. But in case this doesn't work, then from our view, then the patient is a good candidate for DBS. Yeah. Okay. There's one new question. Are there any external stimulators being developed, i.e. non-invasive? Veerle, that's a good question.
Non-invasive. Then I think of TMS. But the problem with TMS is that there's only a superficial effect. So we, with TMS, we cannot reach the pallidum, which is really deep-seated.
That's true. I mean, there's for tremor and Parkinson's disease, there's a high frequency ultrasound, but this is not a stimulation procedure, but it's rather a lesion procedure. This is without opening the skull, but this is not comparable because it's not reversible. So in our view, this is not an advancement of the treatment. And as if I know correctly, this has not been done for dystonia so far, but I'm not sure because I'm not so much in the literature.
Yeah, and if I can add, so it's invasive because there's also a risk of a bleeding after HIFU.
Yeah. So non-invasive, so Veerle, you're right, only TMS, but this is only done in research, and you would have to repeat it all over every third day to if the effect is there. But I mean, deep brain stimulation is called deep brain stimulation because you have to go deep into the basal ganglia, but there you can have strong effects by applying current to the brain. If you did this in the cortex, you have this is the brain cortex, so to say. So I mean the outer part of the brain. Exactly. If you do, I mean, if you stimulate there, you don't affect the basal ganglia, who are the origin of dystonia so much. So you grasp a lot of motor areas and other areas, but it's not so densely together. So therefore, deep brain stimulation is so important. You have to go deep to the basal ganglia to get the effect. Yeah. Telling us that he had DBS in 2015. Then the leads were moved slightly in 2017, and there's no good response. Is there a different spot from the GPI that's good for dystonia?
I would ask myself if it was a good candidate, if there was a clear indication for DBS.
Mm-hmm. Yeah.
That's always a problem if there's no effect of DBS. Is it related to the fact that the electrode was not well implanted, it's not reaching the hot spot, so to say? Or if there was not a clear indication for DBS, because we know that not all types of dystonia respond well to DBS.
Yeah, it's difficult to judge from not seeing, of course, the patient and to see where the electrode is and so on. It's very hard to tell. But I mean, there are other spots that can treat dystonia, but the GPI is probably the best spot to go. I fully agree with you. Therefore, I would also think that I mean, we know that there are patients who do not have such a strong response. This is also has been shown in the studies. And one would need to find out to see exactly where the electrode is located and so on to give a good answer to that. Yeah. And then there's another patient. Oh no, it's the same cervical dystonia. I have cervical dystonia, and there were so many programming changes, but I only have 10% of improvement in the end. That's, yeah, but this is the same. So I would really check where are the electrodes, is the device all right? And I mean, what we've seen in some patients, for example, with a truncal dystonia, when someone has dystonia, I mean, it's a torsion dystonia of the trunk. When you have this for many years, then sometimes your bones sort of fixate, as we say, the dystonia. So even if you have a good effect on deep brain with deep brain stimulation, you sometimes don't see this improvement because maybe it has been like this for many, many years, and the bones, in this case, the spinal, the spine has already changed so much that even if there is a good effect by deep brain stimulation, then this effect cannot be seen post-operatively. And there was years ago that there was a paper on this, on these non-responders, and I think this was one of the most common reasons for the non-respondents was maybe it was either that the electrode was not at the right spot, or that the disease had progressed so long that the effect was not that obvious.
Yeah. So if a patient comes to us that has already been treated with DBS and there's no good effect, the first thing we do is check the system that is implanted. So we measure the impedances. If these are fine, we perform a CT scan to evaluate the exact lead location in order to determine if the lead is located at the right spot. And if this is the case, I have to say, then we decide, then our conclusion is that this patient is a non-responder.
Yeah, I agree. Yeah. Two new comments. One comment from Italy. I'm next to do the DBS surgery. My dystonia is named Dystonia Europe. Okay. At the moment, I'm not able to drink from a glass normally, only with a straw. Is there a good possibility that I can after the DBS?
I think so. Huh? You agree, Michael?
Yeah. I mean, myoclonus dystonia is hard to treat. It's a very difficult disease, and because also when you have dystonia and then another symptom that is myoclonus, for the ones who don't know, this is like jerky movements, like that looks like a bit like tremor, but it's not regular, but it's very fast movements, and this is coming plus the dystonia. We have operated some patients with myoclonus dystonia at our center as well with good results. So both the dystonia and the myoclonus can improve. But again, it's very hard to predict what will be after the operation is performed. But when you look at the cases that are described, and when you ask the doctors who obviously will perform DBS in your case, then there are chances that this will get better. But nobody can really promise. That's the key point. Okay. I see that there are not new other questions. Oh yeah, no, one last one probably. Any experience with DBS in patients with alienating hemiplegia of childhood and/or rapid onset dystonia or Parkinsonism? Oh, that's a tough one. Yeah.
I was looking at the questions in the chat. Sorry, I didn't hear it well.
So no, it's one question that asks if there's any experience with rapid onset dystonia or Parkinsonism. Yeah, and that's, I mean, there are cases in the literature where this has helped. That's it's a rare disease. Hemiplegia of childhood, I've not seen any papers on that, and I've never seen patients, but we would have to ask our pediatric colleagues. But rapid onset dystonia Parkinsonism could respond. The dystonia and the Parkinsonism can respond to GPI DBS. And this is a very special disease where this is very fast. Therefore, it's often misdiagnosed as a functional movement disorder that is psychogenic. But you can do genetic testing and find out that rapid onset dystonia Parkinsonism is the case. At what intervals is the stimulation titrated upwards? Every week or every few days?
Yeah.
Okay, so I think we can wrap our meeting on this point. So thank you very much. And Monica, do you want to say a few words of conclusion?
Considering all the questions today, I think that this is a hot topic. There is a great interest and lots of good questions and great answers. And I think also still a lot to learn about DBS and what types of dystonia can get help from the DBS treatment. As you referred to a study, Michael, about the DBS and the cervical dystonia. That would be nice also to see for blepharospasm, musicians dystonia. And I also think one important thing for dystonia patients is to talk about your treatment, your dystonia with your neurologist and how the treatment is working. And that's, I think, is a very important thing to think about. And yeah, thank you very much to both of you.
Yeah, okay. So I think the same. It was extremely informative webinar. And we can see on the comments in the chat that participants learned a lot. So I want to thank all of you for joining and interacting. So much questions, so much good questions, and also great answers. I want to thank to our specialists for your time, support, and work you do every day. I want to thank you, Monica, and the whole Dystonia Europe team for their work, because it's taking a lot of work and preparation for these webinars. And our partners who have been supporting us to facilitate this project. And I want to inform you that a recorded version of this webinar will be available on the Dystonia Europe YouTube channel and Facebook. So if you want to watch it again or share with others, please follow our social media channels. And we also have a lot of material on this topic on our YouTube as well, so you can check this out. So thank you for taking the time to come to this webinar, and we look forward to having you at our next webinar. Have a good evening. Bye-bye.
Thank you, everybody. Bye.